Hello, my name is Aaron Timms. I am a third-year medical student, currently on my final block as an MS3. This presentation is for the pediatrics residents and everyone else who cares to join us today at Wright-Patterson Air Force Base. Today we're going to be considering a survey of select pediatric chest X-ray cardiac pathologies. So what lies ahead for us? Initially, I was wanting to do a survey of interesting pediatric imaging, but frankly, that didn't work out. Way too much content there, so much that's interesting in the world of not only pediatrics, but pediatric radiology. So I thought I would narrow the focus down to survey of interesting pediatric chest x-rays. It's the same thing there, so much that we could delve into and not enough time to be able to really do it justice at all. Finally, we did settle on a survey of select pediatric chest x-ray cardiopathies. We're going to be going over 4 selections today, which I think that we'll wind up having time for, and hopefully this will be beneficial for everybody and enjoyable for everybody. So this is our first image here. Just going to go ahead and pass it on to everybody. Got 10 seconds, think about it. Get a differential in your head. What is the read here? I'll give you 10 seconds. All right, so this one, I started out a little bit mean. Sorry about that. This one is actually normal. This is a neonatal patient, and you might at first glance think that this is cardiomegaly, but it actually ends up not being the case, and it's because of the size of the thymus in the neonate. While for a normal adult, cardiomegaly is above 50% of the cardiothoracic ratio, that is the space, the ratio between the cardiac silhouette and the overall thoracic cavity. For the infant, you wind up having something about 65% or greater winds up being cardiomegalic. The image that I showed you, that black line, the arrows there, you could really easily say, well, that's more than 65%. But as I alluded to, the thymus in the neonate winds up coming against the side of the heart on both the left and right side of the cardiac silhouette oftentimes, and can misrepresent the actual size of the cardiac silhouette. So you can appreciate that a little bit down here. You see the thymus in the neonate in the image here, as well as the size of the thymus in the adult. Sometimes this can even completely regress as far as grossly in the adult. And this is the thymus of a neonate cadaver. So we can see where you're having some of this, like the cardiothymic notch for the right and left side of the thymus and heart there. As far as the image itself, you can see that same notching here, and we can use that to actually determine the true cardiothoracic ratio and help us to get an idea of whether there is cardiomegaly in the infant or not. Alternatively, you can sometimes get a better picture simply by repositioning the infant. Instead of having the infant supine as you see in this image, if you have the patient repositioned to a upright position, oftentimes the thymus will remove itself out of the way of the heart, and you'll be able to get a better impression of the size of the heart. If that doesn't work, you can, if you really need to know that cardiothoracic ratio, then you can resort to various glucocorticoids, and they can cause the thymus to temporarily shrink down and give you that cardiothoracic ratio that you need. Okay, here we go again. Another 10 seconds and tell me what the read is. All right, so this one here, tetralogy of Fallot. So you see the boot sign, if you remember that from back in cardiology. That boot sign is made up of 4 components. You have the apex of the heart being rotated superiorly. You have something called oligemia, which is effectively low blood volumes in the fields of the lung. You have an enlarged aorta, which you can see better in this image right here. I don't see it as much here, but you see a little bit there. And the pulmonary artery segment concavity, that's this part here, which looks like the front slope of the boot there. So just as a reminder, tetralogy Fallot has 4 components to it. You have the overriding aorta right here, pulmonary stenosis, so you can't get the blood up into the pulmonary arteries. You have a VSD, which allows for blood to move back and forth from the 2 ventricles, and a right ventricular hypertrophy as you're trying to get this blood through that stenotic pulmonary valve. Read number 3, let's go. Okay, and what is the answer? And this one is transposition of the great arteries. I love the signs that you get in radiology. This one here is called the egg on a string sign. Sometimes you just call it an egg sign, but you can actually see, like right there, looks an awful lot like an egg. And you can see this in different orientations. I have also seen it more in this orientation. Maybe I made this part up here a little bit too long. But nonetheless, you still see that distinct egg shape even in an upright position radiograph. The overall pathology of this condition is a congenital, effectively switching of the pulmonary artery and aorta. So instead of the right ventricle pumping into the pulmonary artery, the left ventricle winds up pumping into the pulmonary artery. And what you essentially get is this closed loop where the pulmonic system is a closed loop, and the body system is another closed loop. This would ultimately prove fatal without the PDA at first, and oftentimes, they'll wind up doing adding an ASD, blowing out a little bit of the atrial septum to allow for more mixing of blood to get better oxygenation to the body tissues. Ultimately, you're going to need to have surgery in this situation. It's called if I'm remembering correctly, atrial switch operation, ASO. And what you effectively do is, just like the name implies, you swap those great vessels and put them roughly back where they're supposed to be. It's not an exact positioning back to where it's supposed to be. Because of that, it can wind up causing some pulmonary stenosis and the like in the future. But, there is a 95% 5-year survival after this surgery. And it is what needs to be done in order to ensure that the patient will likely survive. But it's a great advance for the field. Okay, our final read. I'll give you 10 seconds again. Okay, let's see what it is. Coarctation of the aorta. This one is fairly interesting. You'll wind up seeing a few signs for this. For one, you have the hourglass sign, which you see here in the red there. Also, these little green arrows, I don't know if you can appreciate them. Hopefully the screen is large enough, but they're actually pointing to notches in the ribs. And these notches form as a result of collateral vessels forming to accommodate the lack of blood flow through this stenotic portion of the aorta. Um, Interestingly enough, depending on where that coarctation is, you'll wind up having notching on one or both sides. If the coarctation is right there before the subclavian goes off to allow blood supply to the left arm, then you won't wind up having these here. You'll only have them on the side that has the appropriate amount of blood that it can pull from to help feed the rest of the body, which can help determine, if you're seeing just this hourglass sign, it can be hard to know where exactly that coarctation is. But with the lack of the notches on one side, it can help narrow down where this likely is so that treatment can progress. Like I mentioned, we are already past our 10 minutes. There's so much more I would like to talk about. I was thinking about respiratory distress, various kinds of GI conditions, some neuro, all of this, but we're going to stop here. This has been really enjoyable for me. I hope that it's been enjoyable for you, and you have been refreshed on some things that you have no doubt seen before. Thank you for the opportunity to chat with you today. Thank you for the opportunity to put this together and learn from you all for the past 3 weeks. I really appreciate the time that I've been able to spend here, and I look forward to working in this incredible field of medicine with you guys in the future.